So for the next presentation on robotic LAR, differences from lap surgery, I would welcome Dr. Deepak Govil. So.
Thank you, Chairpersons. Good afternoon, everybody. I must thank the organizers for giving me this opportunity. And if an expert like Dr. Saklani is operating laparoscopically, there are hardly any differences you can elaborate, even if you do it robotically. But technically, yes, there are some differences which I would like to highlight. I would be speaking on the differences from laparoscopic surgery, and I would cover that in, I'll just, a little introduction to the robot, especially for the advantage of juniors who haven't seen a robot or who don't have a robot, the general differences from laparoscopic surgery, although majority of you would be knowing majority of these. This is the robot, the three parts, the console, the monitor, and the patient cart, which has 4 arms which are docked to the abdomen on the ports. And this is an older one, SI model. While we were operating, you can see the finger controls, the foot controls where you can control the camera. This is the monitor. The insufflation is the same as you use in laparoscopy. And this is the patient cart, the arms which are docked to the ports on the abdomen of the patient. The general differences, laparoscopic surgery, you have much longer instruments while you're operating. I think that is one of the important things, because while you're operating inside, you're moving in an opposite direction, and that is why the learning curve is much more in laparoscopic. Doing an advanced laparoscopic procedure is more difficult than a robotic procedure because of this reason, and especially the suturing while you're doing laparoscopically, it needs much more expertise and much more practice before you start doing these procedures. Like in this robot, you can see what you're doing. It is more akin to an open procedure. That's why there are a lot of oncosurgeons who have directly started doing a robotic procedure rather than going into the, you have to have basic knowledge of laparoscopy, but you can do robotic procedures even with that. The main advantage is the magnification. The magnification is much more, you almost feel immersed in the field. Like you can see the structures much more like you can see this ureter. People say that there's no sensation, the tactile sensation, but the magnification really compensates for that. And the third arm which you have, it's so stable. You can see this third arm holding. You can't rely on an assistant, but this is stable, and you can dissect the whole thing very clearly and identify and clip. I'll put a brief video of robotic LAR, the basic steps. This is where you start, the air insufflates, and then you go into the avascular planes, and the whole surgery, monopolar scissors is the main instrument which is used for this dissection, and this is a bipolar grasper which is used to grasp, and the third arm retracts from the distance. This is the IMA being ligated, and the nerves also, like you can do a dissection, and because of this magnification you can identify the nerves at the base of your dissection. And even in the pelvic dissection, the nerves are above this, like you can see this is hypogastric nerves which are going the left and the right hypogastric nerves, and usually we go posteriorly first, deep posteriorly, whatever maximum you can go robotically, and then you go on to the sides. This is the right lateral dissection, and again you can see the traction and counter traction, which is the main principle behind colorectal surgery. And the arms like this monopolar scissors has endorist movement of 360-degree mobility, which can be easily seen in the depth, especially in a male pelvis with a bulky tumor. You can really have this advantage much more than a laparoscopic procedure. A lot of people laparoscopically use a harmonic at this stage because they're more comfortable with that. But the planes which I think the heel told and the planes which need to be maintained are much better maintained if you do a sharper dissection with the help of the scissors. Like in this, you can do a sharp dissection and go all around the rectum. And this is the pelvic floor you're reaching. And after this dissection on both the sides, again the third arm retracting. This is the pelvic floor dissecting. These are the seminal vesicles you can see. You can see the scissors doing a wonderful dissection in this area, and this is in great depth you are operating. And after this, we usually, to preserve the nerves, this is the pelvic diaphragm. The laterally, you preserve the inferior epigastric nerves, and this is the pelvic diaphragm. And after this, we use a suprapubic port for transection, because with that you can go quite low down for transection. This is the stapler we use for transection, and then an anastomosis. After we do a thorough washout, do a circular anastomosis, which is a standard anastomosis with the anvil and the circular stapler. And after this, you just check the donuts. You can see this. This is a standard anastomosis anyway. You check the resected donuts, put in a drain, and then come out. Now, after this, I'll be highlighting some of the differences which we can see, small clips which are there. I'll just show you. There's the drain placed. And this is the specimen, the cylindrical specimen. Autonomic nerve preservation is one of the important things. I think robotically the vision is so well that you can identify the nerves better. Like in this case, we've been able to demonstrate all the nerves. This is the superior hypogastric plexus, the right hypogastric nerve, the left hypogastric nerve, and the ureter, the left ureter, the left hypogastric nerve just medial to the left ureter, and the right hypogastric nerve medial to the right ureter. This is very clearly seen. And then you can see the pelvic diaphragm all bared up of the tissues, and the rectal stump over here. Then another thing which this next clip I have borrowed it from Dr. Somashekar, because we haven't started doing this, but I feel we would be going ahead with this, is intracorporeal suturing, which is much more easier in robotic procedures. Instead of using a stapler for transection, you can use transection with the scissors and suture the distal and the proximal ends, and then do an anastomosis. So you save the cost of a stapler for transection, and also you can go significantly low down with the while you're cutting directly, rather than putting in a stapler. Because of the space, the stapler can only go up to a level, but while you're cutting, you can dissect and go significantly down. And in this, they've also like this is the stump which you suture, put in a purse string. See, the needle holder turns in all directions. This anvil, you can put a anvil and put in a purse string inside only, and tighten it up. With the robot, you're almost doing like an open procedure, and you're more comfortable doing these suturing. They've also removed it transanally, the specimen, and after you remove the stump which is left, you can suture that and then put in a purse string here. You can see this so magnified, and put in a purse string in the distal part, and then do an anastomosis. I think this really takes your dissection very low down, and you can do a good anastomosis even after ultra low resections and intersphincteric resections. This is the anastomosis we are doing. just checking the anastomosis with the water, saline. Then Firefly also has, with a robot, it's much more easier to use because you can just put on throw a Firefly and you can see that the vascularity of the stump where you have to resect, it may be sometimes difficult and different while you're doing clinically, it may be this, but if you see the blood supply is only up to this area, so you can modify your transaction levels depending on the Firefly, which is much more easier. You don't have to have another instrument, another magnification system to see all these Firefly, all these fluorescence. Then obviously in distal margin, with the help of the robot, we are able to push the boundaries and do more and more sphincter preserving procedures and going on to ultra low resections and intersphincteric resections. You can see the dissection deep down is so bloodless and in planes that you can dissect in the intersphincteric planes so easily and then do a coloanal anastomosis later on. These are the planes, and like this is what you can do with the robot. These are the planes you're dissecting. So the whole procedure, we mainly require this monopolar scissors and a bipolar forceps and a grasper. These are the three instruments which we use. Many people use only two instruments, in fact. For the third, they use either a traction suture or a third assistant to hold a retraction. But the advantage of the third instrument is definitely that the traction becomes much more stable. But there are limitations of the robot also, like you have a fixed position during surgery. During surgery, in between, if you want a head low or head down, I don't think you can do it unless you undock the thing and remove the instruments. The splenic flexure, we had a lot of issues initially. This is the dissection. If you do robotically from medial to lateral, you can see the pancreatic border so clearly. And you can keep dissecting medial to lateral, and then you go on to the lateral part. So we had initially, while we had older model of SI robot where this was, the changing of the regions was not easily possible, we started doing hybrid procedures where we were doing laparoscopic splenic flexure mobilization and then docking the robot in the pelvis. And cost obviously is one of the major concerns for the robot. So overall, to conclude, I would say that the autonomic nerve preservation is one of the major advantages. Distal margins, we are able to push the boundaries with the help of the robot. Statistically, the outcomes have been similar and not inferior, although there are studies which are coming, which are showing differences in favor of the robot, but they are not statistically significant. Quadrant limitation is overcome in the newer models. The cost, obviously the newer robots and wider use will definitely help the cost. Thank you. This is our team at Indraprastha Apollo Hospital. Thank you very much from the department.
Thank you very much, Dr. Govil. Really enjoyed. I think initially the hurdle was the cost, as you said,
Yes.
and people obviously would want a superior result from laparoscopy to justify the use of robot.
Right.
Now it's been confirmed that for middle and low rectal cancers, obese patient and male patients is quite useful.
Definitely.
Now you have clearly demonstrated that. I don't know, I've not obviously used robot myself. You know, we work in Charitable Cancer Hospital. But what do you think for, at the moment, especially if you have that issue of splenic flexure mobilization, is it worth using robot for all the cases, or is it like, really have to select cases where you can
So now
justify
with the
it?
latest models, fourth generation robots, you can change the direction and use the same docking thing. You don't have to reposition the robot and the patient.
So with the same docking,
things
you
have
can
become much
actually-
more easier.
So with the same docking, you can go to the other quadrant as well.
Yeah. So splenic flexure mobilization, you can do with the same position. Just put an additional port and change the position. So it has become easier now. Initially, it was definitely a problem, and we were doing a lot of changes, permutation and combinations to mobilize that. But I think robot definitely helps. The dissection is much better with the robot, and especially in mid and low rectal cancers, as you've already told, definitely there's an advantage.
With the X and XI, there's no need, sir. We can use a single docking.
Yeah.
It has to be little oblique. The XI and XI are very slim,
Yeah.
and easily we can rotate around.
Yeah.
And of course, if the patient can bear 45,000 rupees more, robotic staplers can be used.
Yeah.
Like instead of suturing, we can push the anvil inside and then staple down, and we can take it out to a hole to the colon.
Yeah.
So it's become easier now, actually.
I think these staplers have also made a difference. Sure forms.
Any other question from the crowd? Any doubts? Thank you.
Thank you, sir.